We're nearly there. Okay, we're live. Welcome to ICGRx. I don't know if you've already heard me say what I've already said, but just a quick introduction. We're here for the Future of Health Education keynote session with some world-class speakers today, and we're really grateful that they can join us. They'll be sharing their global experiences with us, and we'll be really keen to hear from you as well. So if you use the hashtag ICGRX Live, if you tag at ICGRX on any of the social media platforms, the ICGRX team are working hard behind the scenes to monitor your comments and bring them live to the panel. So without further ado, I'd like to ask the speakers to introduce themselves. If we begin with Professor Jed Byrne from Health Education England.
Good evening, or whatever time it happens to be. My name's Jed Byrne. I'm a surgical oncologist by profession, but I'm also the Director of Global Engagement at Health Education England, which is the National Health Service in the UK's workforce arm. I'm a surgical educationalist fundamentally at heart, and I believe powerfully that the way in which you transform healthcare is by improving education, by reacting to the clinical environments in which our patients and populations live. I am deeply committed to positive change in health education, but like most people who are baby boomers stroke Generation X individuals, technology has been something which I have grown up with but never completely understood. I'm really delighted to be here this evening so that we can have a real debate of about what the new normal will look like in the era post COVID-19. And for those of us who have from Generation X who suddenly had to become digitally native, how that will impact on some of the things that we talked about for years, like knowledge acquisition, knowledge transfer, knowledge synthesis, virtual learning spaces, global learning environments, the breaking down of place-based and professional silos. So really looking forward to what I hope will be a very exciting 50 minutes or so. Thank you. You're on mute, Raj.
Say, the wonders of technology. Thanks so much for that introduction, Jed. If we can have a quick introduction from Professor Kumar.
Thank you very much, Raj. Hello, everybody. Lovely to be here. And sadly, we can't see where you are, but you can, I suspect, see all of us. No, I'm equally excited, as Jed said, to take part in this debate. I've really spent most of my life in education. I'm a gastroenterologist by trade, so to speak. And I've really worked in the East End of London and the North End of London most of my life in the NHS. I've also, because of the book, had a tremendous opportunity to travel around, and I hope I've seen some of you in some of the places that I've visited. I think I was trying to count out, I've probably been to about 40. So know a little bit about education there. But really for this evening, sorry, as Raj said, I'm from Bart's-on the London, which of course is the best medical school in the world, without a doubt. So I won't contend that one. So we really are working in the most amazing time at the moment. We were moving forward very fast beforehand, but now with the pandemic, I think we've got to sort of change our thoughts a little bit as to how we're going to be practiced in the future. But really, in terms of changing things, medicine's changing. We've got new diseases. One which, of course, we all know about is obesity, which has problems with diabetes, and then Geeta's eyes as well, and so on. Science is changing. We've made tremendous strides, particularly on the genome side. And I'm on a couple of committees for the 100,000 genome, where I can actually see where we've had positive impact by having found genomes in a rare disease and being able to inform the next generation as to where they'll be going. As Jed said, huge innovations in how we think, how we move, what we do, and in terms of technology, and some of them he mentioned, But also, I think there's got to be a transformation in medicine as we go. And just want to remind you of an editorial which always comes to mind, which was written in the Lancet in 1999. So that's several decades ago. But it was Sir Chandler who said medicine used to be simple. Sorry, I've forgotten it. It's simple, ineffective, and relatively safe. But now it is complex, effective, but the potential harm that we can do to our patients has increased enormously. So I think it's a totally different scenario that you're all going to be working in. And I think because of that, we're going to have to think about how we can educate virtually, simulation, and so on over the years. So thank you, Raj. I hope that was all right as an introduction.
That was brilliant, Professor Kumar. Thanks. One of my favourite quotes as well. Actually, although I studied at King's and so we have the Chandler building there, I actually heard that quote for the first time in California at a patient safety camp. Yeah, it's an incredible quote. And moving on to Professor Charles Mikela. I will unmute you. If you just unmute this, great.
It's called the rat disease. Hello, good evening, everybody. Charles Mikela is my name. I'm a general practitioner. I've been a general practitioner for many years, practicing in Zambia. I practice 10-15% now, and because I took an epidemiology career path, so I'm a professor of epidemiology and as Raj said, founding dean for the School of Public Health. So I have been living in an interface, basically balancing between a general practice and educational management, as well as research. And interwoven in here is education and the role of education, and for which, as my colleagues earlier mentioned, we are living in interesting times where we need to innovate several things. So, and working in Zambia in a low-income setting brings its own dimensions, for which I'm willing to share. Thank you very much, and good evening.
Thanks very much, Charles. I'm really grateful to have your perspective here. Moving on to Professor Jane Dacre.
Hi, hello, I'm Jane Dacre. I'm the former president of the Royal College of Physicians. I'm a physician and rheumatologist, and I work in London. And in the UK, London has really been, or was the first focus of the COVID outbreak. So we were hit very hard and very early on. By background, I'm a passionate physician. I believe that medicine is a brilliant career and is a brilliant thing for people to go into. I started with an interest in clinical skills and then moved on to looking at assessment, because I passionately believe that good quality assessment and good quality education can be a driver for change. In looking at what needs to change in our health service, or in health services all around the world, unfortunately, the science isn't enough. What we're seeing more and more of is inequality. The Black Lives Matter movement shows us that inequality has had a serious impact on the way that we deliver care and the way that we deliver equal quality care to people. And so my other interest has been in developing equality systems and changing systems in medicine so that people can be educated to be the best professionals that they can be. And at the moment, that professionalism plays an equal part in the education of doctors to all of the science. So delighted to be here and delighted to answer your questions. Thank you.
Thanks very much. Without further ado, moving on to Dr. Kieran Walsh.
Hi, Raj. Thank you very much for the invite. Kieran Walsh, my name. I'm Clinical Director at BMJ. I help look after BMJ Best Practice, which is our clinical decision support tool, and BMJ Learning, our e-learning resource. I'm also adjunct professor at Monash University, where I help with their research program into cost of medical education. What will the future be of healthcare professional education in the post-COVID world? I'm going to take a slightly different tack. In terms of strategy, I hope that it will be a world of evidence-based medical education. So I would encourage people, if you're doing something new, or if you're innovating, or if you have a new idea, evaluate it and do research on it, and do it rigorously, because there will be more outbreaks, and we need to find better ways of continuing to provide medical education during them. So I would say evaluate it, submit your evaluation to a medical journal, I would say that, and share, so that we can all learn and improve as a community and do things better for the future.
Thanks so much for that, Kieran. And last but not least, Professor Menon.
Hi, I'm Geeta Menon, and I, like Parveen was saying, I'm a ophthalmic surgeon by background. I actually did my medical school in India, so I can claim to say that is the best medical school, of course. And I am the postgraduate dean for South London, and I'm also the dean for multi-professional working. So one of the things that has been very interesting in the pandemic is how teams have come together to work really effectively to fight this pandemic, how teams have come together to upskill training and education in areas where, you know, people have never worked before. So ophthalmologists, for example, were being redeployed to critical care, and the upskilling and the training that took place was amazing. The other thing that I have found in the pandemic is that things that I have been trying to do for the last 3 or 4 years have happened at pace in the pandemic. I'm sorry to say that it took a pandemic to make it happen. For example, you know, we're always concerned about the well-being of our doctors. And whenever you go to institutions and ask them to, you know, do something about the well-being of the doctors and or the nurses or other healthcare professionals, the answer has always been that when the going gets tough, that is the first thing that slides off. And now you cannot actually go through any healthcare setup without being plonked with all the different well-being apps, well-being programs that have been created. And what we did was, you know, we decided to develop what was called the wellness induction as a part of the well-being project, which basically means that you have a conversation with each learner as they start, and gives them a overview of what well-being aspects are available in the different areas that they're working in. So to me, this has meant that lots of things that we wanted to develop at pace, like the IT infrastructures in NHS trusts, like the virtual clinics, which were always being put on the back burner, all that has actually happened at pace. So I'm hoping that this is going to be a really good discussion.
Thanks very much for that insight, Geeta, and I totally agree with you. I think, obviously, it's an awful situation we find ourselves in, the pandemic, but in terms of the way it's disrupted education and training, and the role that technology has, you know, found has been eye-opening to healthcare professionals. The technology was always there, but the uptake wasn't, and I feel that this has probably been a big driver for that. So, moving on to some other questions for tonight. I think those introductions have already provided us with lots of food for thought and lots of reflections, and I can see that we already have comments coming in. Firstly, so we have a lot of undergraduate students tuning in. What do we feel the future of health education looks like for undergraduates, and, you know, how has the pandemic affected training, and where do we go from now? So maybe if I ask Professor Jed Byrne to comment on that, and then everyone can join in as they see fit.
Thank you, and wow, what a question. Well, let's, I mean, I work within a global context, and I suppose the first thing I'd point out is even prior to COVID-19, we had a woeful shortage of healthcare workers to deliver universal health coverage across the planet. And the variable figures quoted by the WHO and the UN are somewhere between 15 and 20 million healthcare workers short over the next decade. The reality is, however, that COVID-19, perhaps more than any other time, has showed us that traditional educational methods for developing doctors and other health professionals are only partially the best way of doing things. And I think the advent of technological solutions to working at distance challenges us really to look at new ways of learning. What is interesting, however, fundamentally, is that healthcare professionals are, by definition, people, and that one can only become a good clinician by interaction, and not just interaction by conversation or dialogue, but interaction through touch and the use of the senses. That is the way in which we become good clinicians. So the new normal for me has to be a blend of what we know is good from the past, the use of technology as we've learned to use it over the course of this pandemic, and novel and frugal innovation, which will allow us to learn in the place that we were born and have grown up. The only reference I'd like to make to this is some years ago, I was speaking to a very, very well-known international health entrepreneur called Devi Shetty, who runs the Narayana hospitals in Bangalore in India. And he believed with a great passion and as a great visionary that the future of medicine relied on the creation of one or multiple global medical schools, where we learned collectively as undergraduates in using technology, but learned the clinical side of our craft locally, so that the need to travel, but also the reach of high quality education could serve both local populations and also be shared across the planet. So I think we're at a crossroads. I think we should grasp that those challenges and those opportunities that we find ourselves in now, and look for a new normal in undergraduate education.
Can I add to that, because I'm running the project locally to try and get medical students back into our hospitals. And the plan that we've come up with has absolutely had to be the sharing of central resources that are delivered either synchronously or asynchronously, and to reinvent small teams or bubbles of students that have very intensive clinical experience whilst being attached to their seniors or the doctors that are already qualified. And some of that has been developed from the support that the clinicians have had on the firms in hospitals when they've been really short-staffed with very sick COVID patients. And the medical students have universally stepped up to the plate, got involved, and in fact, the feedback to them about their learning opportunities was absolutely extraordinary. So what we've been doing is something that some people in the medical Royal Colleges have wanted to do for a long time, which is reinventing the old style clinical apprenticeship firm, but with better quality knowledge training to go alongside that. So I think the future is actually more positive than we might have thought.
Thanks, Jane and Jed. I'd agree with that. I'd just add a couple of points. Students should obviously look after their own health and follow guidance on what to do if they become unwell themselves, and show really good example to the public. Some of them might have a pre-existing condition, and we need to take that into account sometimes also. And obviously, if in the clinical environment, they need to have protective equipment.
Could I also come in? I entirely agree with what everybody said, but just going back to David Shetty, who, as Jed was saying, has this idea of setting up a sort of a global program. In fact, I made him actually, while he was flying back to Bangalore, send me an outline of it, because I think what we must realize is we're not training students and young doctors for a specific country or specific locality. it's got to be global, because as we just discovered, diseases travel very fast. So we need to know what's already going on. So trying to get the worldwide universities and people like Jane and Jed and Geeta here into actually redesigning a curriculum which would be usable all across the world. And the other thing, I think, one could argue, health education costs in this country 4.2 billion a year, and that's undergraduate and postgraduate. And I think in America it's trillions, it's 1 point something trillion. So it's really very expensive. And I sometimes wonder whether we really do need a 5 or 6, in some countries, a 7-year course of for medicine. Can't we sort of? I mean, my idea in the past was always, because we, as I think Geeta was saying, we're all now working together, and why don't we have a 1 year where all everybody who wants to be a healthcare worker joins in and does generic studies about patient communication, environmental medicine, epidemiology, global medicine, or something like that. And then they focus into whether you want to be a nurse, you want to be a pharmacist, you want to be a doctor, or whatever. And then we could actually shorten that, because one is that the first year would be, in a way, cheaper, more economic, and also get us all mixing, so realizing what other people think in different specialties. But later on, we could then maybe have a 2-year course, maybe 3 years of basic medicine, and then just a few people go into specialties, because you don't really need the whole world doing the same thing. Because if you then become, a rheumatologist or gastroenterologist, as I am, then you would obviously train in that level to a higher level. So going back again, yes, global education. Yes, can we make it more appropriate for what we are going to be using in terms of helping our patients? And also, can I just also emphasize something which both Geeta and Kieran have said? Please look after your own health. I am president of the Royal Medical Benevolent Fund, where we actually look after people and doctors who have actually broken down, not because they will break down, but because of the stress of what we're asking you all to do. So please do look after yourself. Thank you.
Can I come in? Parveen, you've actually talked about my dream of actually training people together as teams, the multi-professional teams. So this is like absolutely brilliant. I mean, I wish that day will come when you actually are training together, so that that medical student doesn't look at a student nurse and wonder what she's doing over there. And they're trying to, what they've done is they've trained everybody in silos, and then now they're trying to bring them all together in teams using simulation, etc. But if they were actually training together from the beginning, it would just be so wonderful. And for example, this year we actually got our foundation, our medical students, the final year medical students, early on into hospitals as F1 doctors, as foundation year 1 doctors, and they were called the interim F1s. And the program has gone so well. It's just been amazing. So, I think maybe that clinical assistantship that needs to happen in that final year of medical school, it'll really be very, very good for these doctors to then not actually reach that phase where they come in and they're thrown into the deep end with the clinics and, wards, etc. So I think that's my dream, Praveen. So if you can make it happen, you've got me.
Great. I think.
Let me quick, a very quick addition to, of course, that interesting comment by Praveen and Geeta on training teams, and I think this is also what I believe in, and this is what we should be moving in. But I have been asking myself a question in the light of COVID, that some of the things that that we've been grappling with are behavioral science in nature, social science in nature, and basically people who are making decisions either for procurement. And so I began asking how prepared our curricula to include some of these, social behavioral dynamics of medicine. And many years back in the medical school in Zambia, when I brought in the idea of bringing this, I was informed that, well, maybe that is diluting medicine. But it looks like that's where medicine is. And so our curriculum must be alive to that. And it reminds me that I do not know the educational system in your country, but in our country, even in high school, therefore, people who come to medical school must have passed the sciences. They should not do the literature, the history. And yet, when we're having challenges like COVID-19, we had to remember what happened to the Spanish flu. Isn't that history? What happened for us in cholera? Is that history? And those are the things that we have left in our curricula. So we need to remember to remodel some of these support elements in the educational system so that we are training a complete being. Thank you.
Thanks very much. I think those comments just echo how much synergy there is amongst all of us that recognise the importance of global health, the importance that actually we're not training students to be working in one small geographical area, looking at demographics of that area, but actually appreciating how health is global. And I think the pandemic, as you've all rightly shared, has brought that to life. We've received lots of questions. I'm conscious that we won't be able to cover all the questions. Can I just ask the speakers if you're all okay to carry on till around 8:10, 8:15, max? Okay.
Yeah, that's fine by me.
Great, thank you. So we've got an interesting question that's come through, and I guess this has a lot to do with how technology has disrupted healthcare provision recently. And that's telemedicine. So for example, we have seen primary care in the UK almost revolutionised in over a week with virtual consultations, whether that be through telephone or through video. And of course, students aren't being trained to use them as yet. We don't have OSCEs looking at virtual consultations. It'd be interesting to hear the thoughts from the panel. I guess we will start with Dr. Kieran Walsh, if that's okay, and then take it from there.
Hi, thanks, Raj. Yeah, I'm sure that virtual consultations and telemedicine are going to be an important aspect of medicine and healthcare in the future. They must be part of healthcare professional education, and they must sometimes be part of assessment in medical education. One thing I would say I'd be keen on is to see what roles patients could play in education on telemedicine, and find out what things patients would really value in telemedicine consultations, and how they could feed those back to the students or learners, or indeed help in assessment of students or postgraduate learners in telemedicine consultations.
Can I maybe challenge a bit and say that I think we've been rather slow to adopt telemedicine? And I agree with colleagues that have said it's been the pandemic that has sped it up. So trying to do virtual clinics was a real problem locally, and then suddenly it all got set up within a week. But one of the things that didn't get set up at the same time is access of students to those remote consultations. And so the technology is there, but we need to now think, what is the best way of the students getting the best opportunity out of those telephone or virtual consultations? Should they be taking a history before you go into the virtual consultation room? Should they be sitting there next to the consultant? What do we do about consent? How do we maintain confidentiality if you can't see who's in the room? There are a number of things that make it a little bit more complex, and in an ideal world we'd have thought about it before, but because we didn't have to, we didn't. So I think we've been a bit slow and we need to catch up.
Yeah, can I come in there? So I totally agree, Jane. So it did take a pandemic for it to get started. And it's interesting, you know, when I went to Zambia and needed to set up the IT infrastructure, it took me literally just 2 weeks to do it. I just told the guy, this is what I need. This is how the database needs to look. This is how the images are going to be transferred. 2 weeks compared to when I set up the screening program in Surrey, when it took me nearly 18 months to get everything sorted, you know. So I think that what Kieran said is absolutely right, that, you know, we need to find a way in how we can actually train our future generation on how to use these things. But it is about deciding which, you know, now they've come up with so many models of virtual consultations with video consultations, how, you know, how you can actually have the trainee in the room with you in the virtual consultation to do that. In ophthalmology, for example, we are one of the highest outpatient specialties. So trying to actually think of virtual consultations and everything was never there in our arena. We used to just need those clinics filled with patients. And now, if you actually use a virtual consultation platform, you're able to actually reduce the patient coming in by 50% for emergency eye care. So, you know, it is something evolving, and I think we do need to actually change our curricula to meet with how we are going to train people doing virtual consultations, because it is about taking that history. How do we actually make sure that nothing is missed out, and how do people just get that feeling of being, you know, doing that virtually?
So could I also come up? I entirely agree with what everybody's saying. And, you know, it's awful to think it takes a pandemic for us to actually do what we want to do. And, you know, I think we always think, oh, well, we can't do that, we haven't got the money or something. But it's been very simple. And I think, as Jane is saying, the outpatient consultation the NHS will never allow outpatients to come back again. Not a waste of time on everybody's part. But the other thing is, of course, we've got robotic medicine where we can actually, or surgeons, I say we know how to do it, but a surgeon can actually put their hands on and manipulate, the patient's hands, the surgeon's hands, and how to do it. And when I was doing these, I'm doing this patient today, again online, and I was dying to put my hand on the tummy. Now I'm sure that's an examination. Because I think the history is so important. I think you can get 80%. I mean, they say within sort of, 50, a couple of minutes you worked out which system it is, and the rest of the time you're just really working out what the finer points of diagnosis. But I think the examination does have an important part. So if you can get a robot sort of feeling your tummy and listening to your heart, wouldn't that be wonderful? And I'm sure that'll come with all these lovely new youngsters who can do computers and work with them. So good. I'm delighted to hear that.
Could I just come in and just make three very quick points to support everything everybody said, but also maybe a bit more controversially. So the first thing I'd like to say is I'd like to apologise on behalf of my generation who've been ridiculously slow in looking at newfangled machines in order to solve problems that have dogged us for hundreds of years. The second thing I'd say is that technology is not the issue. We should be working out solutions to things by identifying what the problem is, then looking for the range of solutions, and then looking for the best value for money and the best offer to the patient. And the third thing to say is that the people that have the answers to what is the best solution, particularly technology, are normally the people at the early part of their career, going through medical school and just beyond. So we need to adopt a reverse classroom perspective and listen to the potential solutions that technology can provide by people who are familiar to that technology and what is the art of the possible with it. And we've been terribly bad at doing that, I think, as a generation who's made decisions over the last 20 years.
I think additionally, Pavini said sometimes we have to wait for a pandemic, and unfortunately, this is what happens. We'll be forced to be in a corner and think. I'm just currently remembering that we have a practice in Osaka St. John's Medical Center, where during the COVID outbreak, we have been seeing only 30% of our normal, clientele. And suddenly we have to start thinking virtual medicine, telemedicine. We had never thought about that before. It has made me think. We have just started a Master of Medicine in primary care or family medicine. Nowhere in the curriculum does it bring a room for telemedicine. And COVID has made us think that we have been carrying a curriculum document that is almost getting outdated, because the realities make us that we have to move with the realities. So yeah, I think we have to. The future is that we have to innovate education and embrace technology and dictate our relevance among the people that we serve, or else we are not relevant. Thank you.
Thanks so much for that. I think everyone's hit the nail on the head, really. As a junior doctor, I feel that medicine has always, been taught in a certain way, and change has been slower than when compared to other industries. But I think some of that is positive in that, we can't just be trialing new things if we don't have an evidence base for that. And I know there are lots of questions around the evidence base for digital health interventions and different styles of learning. But I feel that now there's a growing appetite among students and trainees to innovate, to develop solutions with patients that are digital, working, whether that's through hackathons or through social media engagement. There's such massive communities that have formed. I did my master's in public health, looking at digital health education for healthcare students and professionals, and even at the time, I don't think there's any one health system that has really got it right. And I guess this is going to be a real turning moment for that. And I know that we've been working hard to try and develop a data capture to ascertain some best practice around digital health in medical schools and in health schools, and gain insight to see how we can ensure that the future healthcare professional is digitally competent, not only just using IT and getting an email working, and but actually being in a position to actually use that technology to help create some solutions in conjunction with patients. So I think it's amazing to see the amount of energy that's out there for that. So I guess a lot of what we've spoken about has equal ramifications for postgraduate training. But I wonder if we can just spend 2 or 3 minutes talking about the impact on postgraduate training. And maybe if I ask Jane to start off.
Thank you. So
we've seen some questions around the exams being cancelled, and with the current situation we find ourselves, do you think that things will change? If so, how can we ensure postgraduate training is as good as it?
I think that postgraduate training will have to be different. And I understand from hearing from Andrew Goddard, who's the president of the Royal College of Physicians, that there is a plan to start to get postgraduate Royal College examinations going again by the autumn. The difficulty is with social distancing in exam halls. So there are technical problems that are getting in the way. And then they're also exploring recognition software and having proctoring arrangements so that people are supervised whilst they take their exams. So various different models have been looked at to try and get the exams restarted again. Now that's for the written components of the exam. If we look at the clinical components of the exam, in fact, that's a really difficult problem that has been so far on the too difficult pile, hard to resolve. Using video examination, sometimes you just might miss something. And to examine clinical skills without being in the room with the patient is very difficult, but being in the room with the patient has implications for patient and doctor safety. So the MRCP, which is the exam that I know most about, are having a lot of brainstorming and thinking sessions to come up with options, which they're going to put to the candidates to see which ones they prefer, to work out how to do this for the best. I've no doubt that eventually we will come up with a solution. It's difficult to know exactly what that solution is at the moment, which must be extraordinarily frustrating for our trainees. So no answers yet, but an awful lot of people thinking about it.
Thanks, Jane. Just one small point about postgraduate training, that I think the pandemic has shown us the need for broad-based training, to have healthcare professionals who can look after patients with multiple comorbidities, because it's people with multiple comorbidities who are becoming seriously ill, and multimorbidity is so common. And yet, to look at things the BMJ does, including our own resource BMJ best practice, we only, and guidelines, they only deal with single condition. So we need to do better than that. And BMJ is working on something about that at the moment. But I think the pandemic, if nothing else, has shown us a real need for broad-based training of healthcare professionals who can look after patients with multiple conditions.
Sorry for jumping in again.
Jane,
you're muted. You're muted, Jane.
Sorry, we celebrate the specialist, but we don't celebrate the generalist. And actually the generalist has more sophisticated diagnostic skills because it's across a broader area. But somehow we celebrate and reward the specialist more than we do the generalist. And it's very difficult to turn that clock back. It was something that we tried really hard to do. But one of the problems is that the work in general medicine is so hard and so arduous, and we're so understaffed that people are voting with their feet because they don't want to do it. So we need to find a way of celebrating generalism and restarting generalism as something to be proud of.
Can I just come in there as probably being one of the last people to be trained properly in general medicine before I went into gastroenterology. But you know, at the time when this was happening, I did say, no, we must have the generalist. But of course, the patient want the specialist. And that's the problem, you know, the sad problem about it. But with comorbidity, you've got to do it. Now, I have to say that, you know, when we started writing the textbook, we had great ideas of, okay, let's do it on symptoms, or let's do it on whatever. We then don't know what the background knowledge is that you can then actually be applied to doing all the other things. So I think it's very difficult to teach comorbidity. And I suppose that the par excellence condition would be diabetes, because it just affects most of the organs. And I think you can only do it one by one, but somehow somebody's got to put it all together, and you then do need a general physician. So I'm glad they're coming. I suppose the nearest we've got to that is the acute physician at the moment. But if we can now have the general physician coming up, that would be wonderful, really. Entirely.
Wait, just adding a dimension, I think from the low-income country where we are grappling on the value of a generalist versus specialist. And in the 1980s, we all started.
Thanks very much.
Hello, can I go on? We started specialist training and on focusing on specialists. And yet the bulk of the problem that we're having are primary care related and requiring, generalists. But I think it's time to innovate that generalist training, and so that we are able to meet, I think in our situation, I think low income needs, and public health medicine should be incorporated as that core, in that core curriculum.
We can hear you.
Yeah, thank you. I think I was just adding the role of public health medicine and general medicine training and primary care medicine. Thank you.
Thank you. Can I just sort of support Charles there? The best general physicians that I've met, and I've been to most countries, are actually in Africa, India, and going east, because they all see everything. And one of the joys, I think, for me was practicing in the East End of London, where the world visits us, and you diagnose malaria every day and so on. But I mean, all these patients have got different things, and the general physician is just absolutely important. for the diagnosis.
Raj, I see there's a question up about Black Lives Matter and structural racism. Shall I, do you want to move on to discuss that? Because one of the things that I've been doing over the last couple of years is a piece of research looking into the gender pay gap in medicine. And the biggest cause of the gender pay gap in medicine is actually structural. So it doesn't surprise me at all that there's structural racism, because I think there is structural inequality in the way that we teach in this country. And sadly, because of COVID-19, the report is sitting on my desk. I can even show it to you, and hasn't seen the light of day. And the reason for that is that everything closed down. But there are a number of recommendations that were originally about gender, but actually are about structural inequality in the way health systems work. And I think it's really important that we start to look at structural inequalities and start to make the structural changes that address the issues that we're coming across. And they're in education, they're in exams, they're in the way job applications are made. We've got to have a root and branch review to get rid of the structural barriers to people who are different from the white male getting.
Well, maybe I can join in that debate on structural racism, but bring in another dimension of minorities, disparities regarding our educational system. Even in country like Zambia, where we are not struggling to structural racism, and yet there is a kind of disparity practice, because there are people from poor areas who have no access to education, and we have done nothing about it. And even in our education, to make our educational satellite pilot sites for to be put in areas for the underserved, there are no deliberate efforts. And I think this is what I'm calling another type of structural racism, Jane, and where we have forgotten about about the minorities. Where I have been involved in and reanalyzing Zambia demographic health surveys, and I've been amazed at how the urban poor is so different in Zambia, and we totally abandoned that, and we need to reach out to those. So in our training at postgraduate level, I think we need to bring out these inequities, inequalities, disparities, and yes, so that I think we're able to address, I think, some of these things that people are grappling with. So it's another dimension of the structural racism, white male, now bringing actually the low-income context about poor and rich, gender and socioeconomic status and things like that. Thank you very much.
Thanks very much for sharing those perspectives. And I think see what's happened recently has made us all kind of have a look at how teaching is done, and not only at medical school, but I've seen petitions from my old school around the curricula in history and looking at broader curricula around all subjects, and how we should all be looking to add voices that represent society and not just a select few. So I think I know the Medical Schools Council, for example, and the BMA have been looking into this with the charter, and it's good to see the work that's being done. I know at Health Education England, for example, there is a Shuri network which is looking at digital health with women of colour and seeing how we can support them. And I think there's been in recent months and years, there's definitely been a more inclusive focus. Just before we end today's keynote, I think it'd be nice to reflect on some of the positive changes that have happened during the pandemic and how we can take these forward. And I wonder if we can start with Professor Kumar.
So I was just answering a email. So how can we take all this forward? I think two things really. One was that this pandemic has made us all rethink and perhaps be a little bit more flexible, perhaps get out of our little boxes, and perhaps even think the unthinkable, which I think we were hidebound to do and were in our little silos and wouldn't talk to anybody. So I think that is one good thing. But the tragedy again is it takes the death of a black man to actually get us now saying, look, we've got to do something about it. It's been there all the time and we just don't seem to be able to move. So I think we've got to forget our restrictions. I think we've got to look worldwide. We've got to think openly, fluently, and I think we just need to start off with a template and go ahead with it. Having said that, I think Jed mentioned evidence-based medicine, as did Kieran. And I always think, I used to chair the Medicines Commission for the UK, and if a medicine came online, a new one, we would go through a huge amount of pilot studies, have to go through all the levels of getting a new drug through. But when a new educational thing comes in, they immediately put it out without any thought as to where it might go. And I think if we can all discuss it before we actually put it out, it would make the world so much better. But I think let's all think together, work together, don't have silos, and take life forward.
Thanks for that, Prof. Kumar. I think that a nice way of doing this now is to go to each speaker and ask them for a closing statement on some of their reflections on the session. And I'd just like to say a very big thank you to Health Education England for supporting this session and for sharing our mission to share open access learning, where we can collaborate globally, form connections, form a community to improve health together. So if we move to Professor Jed Burton on some reflections and positive changes to take forward. And just before we do that, we also have an exciting summit happening on the 28th of June. We're sharing more details with similar sessions and an opportunity to share work that all the audience members might be doing across the world. Jed, over to you.
Yeah, I think the pandemic has shown us more than ever that in order to become a complete healthcare worker, you need to learn globally and deliver locally. And that global learning can take many forms, whether it be cultural competence, EDI type education, armchair volunteerism, international placement, international virtual placement, circular migratory pathways, which are focused very much on professional development and trying not just to get the right quantity of healthcare workers to deliver universal health coverage on a global footprint, but also ensure that there is a step change in the quality of the care and health and well-being, navigation and advocacy that health professionals of the future can give.
Thanks, Jed. Over to Professor Charles Mikela.
Yeah, I think the pandemic has made us to know that we are not immune to shocks, both our internal shocks and external shocks. And secondly, that even bureaucrats can change. At the University of Zambia, we had difficulties in starting different forms of e-learning. With COVID, boom, everyone just jumped in. So even the hardcore system people, bureaucrats can change. So resistance is possible to deal with. Thank you.
Thank you. Jane? You're on mute, Jane.
I'm going to take a quote from somebody who's become a bit controversial over the last couple of days, Sir Winston Churchill, and that is to say that we shouldn't waste a good crisis. So I think we need to use the COVID-19 crisis to remember that we should be swimming forwards in medical education and not drifting back. So all of the good new things that have come, we mustn't just go back to the old ways when the crisis is over.
Thank you. Kieran?
Thanks, Raj. My last thought is that COVID-19 is a zoonotic disease, one of many zoonotic diseases like Ebola, Zika, bird flu that we've had over the last few years, and there's more to come. Part of the reason why there will be more to come is because of climate change. And so it's heartening to see curricula in medical education now including climate change, with things like covering things like refugee health or diseases caused by air pollution. But I think medical schools and other institutions, including ourselves at the BMJ, need to do more to think about our carbon footprint as an institution, the amount of travel that we do, and think about other ways of doing things, like this webinar.
Great. And Professor Kumar, I know that you mentioned some thoughts earlier, but if you would you like to add anything further to what you shared earlier?
No, I think everybody's covered it, but I just want to again support Kieran on the climate change. We've seen an amazing decrease in pollution. And I don't know whether we've all seen those figures, the satellite pictures of China, where it's suddenly now okay, and before it was all red, and indeed Europe as well. So I think if you can pursue with that, but how we can actually do that with a clean environment and yet produce things. But if we're doing it all online, we can have clean electricity from wind, what do they call wind things, which are mushrooming up all over. So I think that's agreed, and I agree with Jed and Charles's comments as well. Thank you. And James.
Thank you so much. I think it's been tremendous. I mean, the feedback we've received on Twitter, on Facebook and YouTube, they're really grateful that you've all been able to join us and share your global insights with us. And I guess it just shows how, although we might all be in medicine or healthcare, but the world is so connected, and we need to start thinking more broadly, how we can engage meaningfully in an interdisciplinary manner. And for that reason, for our next session, which is actually on the 28th of June, which is a summit of sessions looking at areas, looking deeper into areas such as diversity, gender disparities, patient safety, the impact on society, and not only looking at a medical perspective, but political perspectives. And I guess, as Professor Charles mentioned, getting the bureaucrats to move faster, and how do we all work together in a team? I think often in healthcare, we see us as us versus them, versus different departments, different specialties, managers versus clinicians. And I guess we need to move from this silo mentality and really embrace open access collaboration. So thank you so much again for all our speakers today for joining us and taking time out. We hope you can join us at our next sessions, and please do join the social media conversations that are happening right now using the hashtag if you can. And on behalf of the ICGRx team, I'd like to thank everyone for joining in today from around the world. I think we've had over 350 people from over 20 countries, which is amazing. And I hope we can continue this collaboration to connect with each other and to collaborate to improve health globally. Thanks very much again, and all the best from the ICGRx team.
Thank you.
Thanks very much.
Thank you.
Thanks all.
Yeah, pleasure. Bye-bye. Thank you. Yeah.
So thank you once again to everyone for joining us. I just received a message regarding the summit, and so the ICGRx Summit is taking place on the 28th of June, 2020. We'll be inviting abstract submissions on a range of areas, such as clinical management of COVID, research and innovation, technology, patient safety, diversity in healthcare, and prioritizing patient safety. We've got a great lineup of speakers, including Professor Bamra, Dr. Kailash Chand, Professor Jane Dacre, and speakers from across the world. So please do join us for the summit. It's totally free to attend, as are all ICGRx events. We're really keen to promote open access learning in health education, and we really want to hear about your projects too. So if you have a project that you've done, it might not have been during the pandemic, but is related to the areas we'll be talking about, then please do log on to our website at icgrx.online to find out more about the submission process. We're encouraging people to share 2-minute videos of pieces of work they may be involved in, and we'll be sharing these live during the summit. If you found today useful and you feel like you'd like to join the team or be a speaker or potentially an organisation that would like to support our mission to share learning globally in healthcare, please do get in touch with us. We're really keen to collaborate with like-minded people in order to continue to form those connections and really support a global health community. So that's all for me. We'd like to thank Health Education England again for their support and the Becoming a Doctor National Health Careers Conference teams, as well as the studio team we have present here. Thanks very much. Take care.